conversation of the Prematurity Prevention Network. This event is brought to you through a collaboration between the March of Dimes and the National Medical Association. Today's presentation is The Puzzle of the Early Detection of Preterm Labor and Prevention of Preterm Birth. Our speaker and presenter today, Dr. Washington Hill, is a renowned expert in maternal-fetal medicine and high-risk pregnancy. Recently named one of the top 100 black physicians in the country by Black Enterprise magazine, Dr. Hill is a clinical professor for the Department of Obstetrics and Gynecology at the University of South Florida in Tampa, and clinical professor in the Department of Clinical Sciences OB-GYN Clerkship Director at the Sarasota Campus of Florida State University College of Medicine in Tallahassee. He has also served as past president, chief of medical staff, chairman of the Department of OB-GYN, medical director of labor and delivery, and director of Maternal-Fetal Medicine at Sarasota Memorial Hospital. Dr. Hill has served on the board of the National Perinatal Association and the Society for Maternal-Fetal Medicine. Dr. Hill's work has centered around education, patient care, teaching, and clinical practice. He has been a leader in the development of a center of excellence known throughout the nation for the care of high-risk pregnancies. As a member of the National Medical Association, he has developed a scholarship fund through the OB-GYN section for minority medical students. And finally, in his spare time, Dr. Hill likes to travel, especially to Africa on medical missions. Welcome, Dr. Washington Hill. Dr. Hill?
Thank you very much for that kind introduction. We're going to talk today about the puzzle of doing all we can to detect preterm labor early and to prevent preterm birth. It's a pleasure to do this for the March of Dimes and certainly for the National Medical Association. I hope those that are on the call and on the webinar will benefit from it, and we should have a very interactive question and answer period. So let's get started. I have no commercial disclosures or potential conflicts of interest. These are our objectives. We're going to describe the possible etiologies of preterm labor. We're going to try to understand the ongoing puzzle still present when diagnosing preterm labor and preventing preterm birth. We're going to describe the maternal and neonatal complications associated with preterm birth, and then we're going to try to describe and understand our remaining challenges in preventing preterm delivery. This is what it's all about, and this is what we're trying to avoid. Many of you on the call have been involved in trying to prevent preterm birth for years. In my career, it's been 20 or 30 years, and in many of your careers, it's been longer or perhaps shorter. But what we're trying to do is to prevent the delivery of this preterm infant. Sometimes we can do that, and sometimes we cannot. Let's start with the case. Betty is a 25-year-old patient seen with her boyfriend. She recently was diagnosed with a positive pregnancy test and has a history of substance abuse. Betty was referred to us for ultrasound evaluation from the emergency room because of a questionable pregnancy and bleeding. Her ultrasound shows this. And as you can see, there's an A, B, and C there on 3 gestational sacs. So this is triplets. So what does she now need to know? How does she assess the right care? Who should we refer her to? What services are available to her in your community, a patient with substance abuse and triplets? What problems might she encounter during her pregnancy? What should be our goals for her? How far do we think she can get? Can we prevent her from delivering preterm, and where should she deliver? There are multiple challenges you and I face in preventing preterm birth, whether it is a singleton or multiple gestation that Betty has. And these challenges have existed for many years. So let's talk about these challenges. Combating preterm delivery is similar to a puzzle. for which we have some but not all of the pieces. This is the puzzle. The pieces of the puzzle, as I have presented this over many years, really have not changed. I've not changed the title of the pieces of the puzzle. What has changed is what's behind those pieces, and it's still changing. The first piece of the puzzle is access to prenatal care. And in dealing with access to prenatal care, are there enough facilities in all the counties? For example, in Florida, there are some counties where we do not have an OB-GYN physician, and that care is then provided by midwives. So think about that in your own area. Are there enough facilities, or are there enough health providers in the county? Do we turn off the patients? When a patient comes into us and we see her for the first time in our OB triage or at the desk, are we receptive to her? Are we kind to her? Do we interact with her in such a way that she's willing to come back? Do the patients turn us off because of their habits? I hope not. Skipping down to the last two bullets, are there friends or partners we have not thought of contacting and need to, such as FEMA? Or what about the parish nurses or the church nurses? Certainly in the African American community, and I'm sure in others, patients who go to church frequently can get information from their parish nurse. And what's with this ethnic difference? This slide, what's this all about? In the African American and ethnic group, you can see that the incidence of preterm birth is somewhere around 17.8%. And look at what it is in the white race, 11.7%. What causes that difference? The short answer is we don't know. The long answer is it involves many things. Access to care, transportation. Patients may not want to come in. Dr. Liu and colleagues in California would suggest to us, we may not want to hear it, that there's some degree of racism. Not that we are racist, but perhaps the way that we take care of some patients leads them to believe that we don't care, and they then don't come back. So this is an area of continuing research, and this disparity is still there. This is the last data that I could find. There may be some more recent data with the March of Dimes, but you can see that the incidence and the percent of live births that are preterm has gone down a little bit. We get very excited when it goes down 0.2 or 0.3%. We're not sure why it is when it does go down, but we're happy when it does go down. But the number of 12.3 or 12.1 or whatever it now is still too high. The next piece of the puzzle is lifestyle modification. Think back to the case that we talked about. Look for substance abuse and smoking in your patients. I'm in my office, and just today I saw another patient who is smoking. I made rounds early this morning. There's a patient in one of our rooms who has an abruption. She's at 24.5 weeks, and she is still smoking. As far as I know, smoking does nothing good for our pregnant patients. We should encourage them and should try to continue to advise them to decrease smoking. Cocaine, as you know, causes preterm labor. The word on the street sometimes is if you want to go into labor, do a little cocaine. Nice study was done by Hayward Brown and colleagues when he was in Indiana that showed if you look at patients who come in preterm labor and do a drug screen on them, and then do a drug screen on the one before and the one after, which one do you think has the positive drug screen? And you're right, it's the one in preterm labor. These patients need to be referred to a community resource. In our community, it's called First Step. In your community, it's called something else. Look for domestic violence in these patients. Constantly be looking for both of these because they're going to be found there. The next piece of the puzzle has to do with patient education. Patient education works, but not as good as we thought or wished. You should be giving this information out to patients who come in who are at increased risk for preterm labor and preterm birth. you probably should be giving it out to patients who are not at increased risk for preterm labor, preterm birth as well. There are many sources for this information. The March of Dimes has it, ACOG has it, various vendors have it. Your ultrasonographer should be giving it out to them when you're doing the cervical length, but we'll talk about it in a bit. We should be giving the preterm labor information out to them. Videotapes or DVDs are available. It's low cost, and it helps the budget. In the original study by the March of Dimes, when I was a fellow and Dr. Creasy was doing it in San Francisco, it showed very nicely that patient education worked. In the larger study of the March of Dimes, it did not show that it worked as well, but we certainly should be still educating our patients about symptoms and signs of preterm labor. The next piece of the puzzle has to do with provider awareness, and that's why all of you are sitting there having your lunch and listening to this discussion. And provider awareness is very important. And this is information from the March of Dimes, their preterm labor assessment and evidence-based toolkit, which originally comes from California, is currently being revised. And it's being revised because of two very important pieces of information that we'll talk about toward the end have come out this year from ACOG, and there's some modifications needed in the preterm labor assessment toolkit. I have to say that the toolkit originally was put together by the group in California. You can find it at the website of www.prematurity-prevention.org, but keep in mind that it is being revised. But provider awareness is very important. We learn from everyone, including your patients and your clients. Every time I give a live presentation, I learn from those who are there because they give you other ideas. We need to teach everyone, including your patients or clients. You need to teach the person, the HUP, or the person who is the receptionist at your clinic. I'll never forget when I was in California, a HUP or the clinical receptionist said, "You can't be in preterm labor. You're not due until December." I took her aside and told her that probably the patient was in preterm labor, and that's why she called. So take the time to talk to those in labor and delivery, whether they be your nurses, your LPNs, or the person who checks in the patients. Treat the whole patient. I had a patient who told me one time, "Dr. Hill, I understand why I'm here on your antepartum unit. I have twins, and I'm at 28 weeks, and I'll tolerate this magnesium sulfate for now. But I really, really miss my family. My husband, who I could never find, does bring in my little daughter, and she has on that same blue dress. But the worst part about being here in the hospital is that my mother-in-law is at home going through my stuff." How many of you right now would like your mother-in-law at home going through your stuff? I don't see any hands. We developed a program called Mom Matters here at Sarasota Memorial, and others have done it as well. It's developed by one of our very nice clinical nurse specialists. And what it does is it helps to reassure the patient that things are going well at home. And women always feel better when they have a pedicure or a manicure or their hair wash, and we make sure that we do that as well. We do not allow them to go outside and smoke. The next piece of the puzzle is frequent provider contact. And shown here are the points and the bullet points behind frequent provider contacts. Be available to see the patient, whether she is symptomatic or not. Provide excellent customer service and look for ways to improve it. All of us have our customer service scores measured, and sometimes it will tell us whether or not we get a raise or not. So customer service is very important, particularly these patients. What's your waiting room time? When she calls, get the patient in for her appointment, or get her in to be seen in the emergency room or into your OB-ECC emergency room. You may be her best contact or friend that she has. The next piece of the puzzle has to do with nursing services. Nursing services are very important. We need to recognize that these nurses' services provide the best care that we can for the patients. The nurses can be an advocate through Healthy Start. They can be an advocate through providing patient care. They are a liaison to the physician. Make sure that your communication is open between you and your physician. If it is not, then you have a problem. And certainly they can be, the nursing services can be very important as an educator to the patient and to the physician and to those in labor and delivery. The next piece of the puzzle has to do with early diagnosis. The earlier we diagnose the problem, we are probably better than able to try to prevent preterm birth from occurring. We need to practice appropriate triage. As you can see here, the earlier diagnosed, the better it is, whether it is a singleton or multiple gestation, for entry into prenatal care, entry into Healthy Start, entry into lifestyle modifications, or just to get the patient on the right track. Here's a case. Take a look at it in a second. A patient with twins calls her OB at 2 o'clock in the morning at 27 weeks. She is complaining of spotting and cramping for several hours. She was advised to wait until morning and then come in for her regular appointment. She showed up in labor and delivery at 7 o'clock, complete, and 0 station, delivering an hour later. Both babies developed cerebral palsy. She went on to sue her OB and also the hospital. Was her OB triage appropriate? Probably it was not. Certainly when the patient called her OB, she was doing what she had been told and to do. And that was, if you're having spotting and cramping, I'm not sure she should wait several hours, but she certainly called her physician. But then when we were contacted, when we as healthcare providers were contacted, we dropped the ball. She then came in complete, and 0 station. The other thing, as several nurses have told me, the worst time for her to come in is 7 o'clock in the morning. That's a change of shift. The night nurses are trying to get out, and the day nurses are trying to get in. So coming in at 7 a.m. didn't help her either, but for sure, the OB triage in this case was not appropriate. The next piece of the puzzle has to do with cervical examination. So we've talked about access to prenatal care. We've talked about lifestyle modifications. We've talked about patient education, and that is very important. We talked about nursing services and how the nurses can help us in trying to detect preterm labor early and prevent preterm birth. We've talked about frequent provider contact, and we certainly have talked about provider awareness and early diagnosis. Now, what about the cervix? In the past years, transvaginal ultrasound of cervical length is a benefit and better than your digital exam. That's been shown for sure, because what transvaginal ultrasound does is it shows us the exact cervical length, what's going on where your finger cannot feel. It's okay to do it, but not with preterm premature rupture of the membranes. And I was so pleased when ACOG in the the management of preterm premature rupture of the membranes came out, indicated that we should not be checking patients with ruptured membranes. And Dr. Carol Major and Dr. Lewis, in an older study now, has shown us that when we do that, the overall latency period in patients with ruptured membranes will be shortened, that the vaginal examination should therefore be avoided, no digital exam should be done, and we should really be doing a sterile speculum examination. So if you don't know how to do that, you should have your colleagues teach you how to do that. So no digital examination in patients with preterm premature rupture of the membranes. This is a transvaginal ultrasound looking at cervical length, and you can see that the cervical length in this patient who had a singleton pregnancy, but what was that increased risk for delivering preterm was 3.0 centimeters. This is some work by Jay Imes, and many of you know Jay, and I'm sure some of his colleagues are on the call. And Jay, in 1996, and thank you, Jay, published in the New England Journal, showed us that the risk of preterm delivery by endovaginal ultrasound could be correlated with cervical length. When I first looked at this, I said, gee, this is complicated. Jay, what are you talking about? But as you can see, it's very simple, that as the cervical length decreases, what happens to the probability of this patient delivering preterm? It increases. We use this information every day now when we look at the cervical length of the patient. Here's a patient. Mary is a very active sales representative for a drug company. She's a prime gravid woman. She was a vice president for the company, did a lot of traveling, and came by my office about this time of the day and said, come on, Dr. Joe, I got to get out of here. She had twins at 23 weeks and was seen for a routine visit. Her cervix was short. She has not had much in the way of contractions. She said, so my cervix is short. What can I do now to keep from delivering preterm? This was her cervix, and she was on the way to the airport because she had a sales meeting in Chicago. Do you think I'd let her go to that sales meeting? I'd let her go home. And yet you can see her cervix here is very short. The normal cervical length should be 3.5 centimeters, as shown by the work of Jay. And here, this patient's cervical length is far shorter than that. So looking at the cervical length is very important. But you need to look at it carefully, and those who are looking at it need to have the experience and the background to make sure that they are doing it correctly. The next piece of the puzzle has to do with screening for preterm labor risk. Wouldn't it be nice if we were able to look at patients who were either at increased risk or not at increased risk? We're able to look at them, do some test or another, and identify those patients who needed more attention. Well, that's what we've been trying to do for the last, perhaps, 20 years. We've not been able to succeed in it as well as we'd like, but we are making some progress. Dr. Creasy and others showed us that if we use risk factors alone, that it was initially promising but not as good as we would like. We now know that it probably only identifies half of the patients who will deliver preterm. Transvaginal ultrasound for cervical length may help us, and using fetal fibronectin in patients with risk may help us as well. There have been a myriad of other tests. Some of you can remember when we did the spit test where we were looking at estrogen in the saliva, and we thought that that was going to help us, and we found out that that was not the case. So we've looked at a lot of other promised tests over the years, but they have not been as successful as we'd like them to be. Fetal fibronectin is a test that has been able to help us, particularly in the patient at risk. As you know, it comes from the area between the chorion and the decidua, and the fetal fibronectin may be very helpful in predicting in patients who are at risk which ones may and which ones may not go into preterm labor. Remember that before 20 weeks, it's normal to have a fetal fibronectin present. This was a study done by Tom Greedy and colleagues, published initially in Contemporary OB-GYN. They were looking at fetal fibronectin in terms of nanograms per milliliter. We look at it now either positive or negative. But you can see that down at 20 weeks, and from 20 weeks to 35 weeks, we should not see any fetal fibronectin. We'll talk about this a little bit at the end. So the clinically relevant time frame is somewhere between 22 and 35 weeks. The value of fetal fibronectin is the negative test. And as I've shown here, based on the high negative predictive value of the test in the area of 98 to 99%, based on that high negative predictive value, decreased levels of intervention are necessary in those patients. We can reassure them, we can avoid patoka litigations, we can just provide ongoing prenatal surveillance, closer maternal and fetal surveillance, and less disruption of the patient's lifestyle. They may be able to continue to work, for example. There are several algorithms for the use of fetal fibronectin. You kind of have to develop your own. This is an algorithm in symptomatic patients, and this is an algorithm in high-risk asymptomatic patients. Come up with your own. Many of you have, and you use these in your patients in your office, or you use them in patients who are seen in OB triage. As ACOG said in the practice bulletin number 130 in October of this year, fetal fibronectin is not for screening in the low-risk asymptomatic patients. So just keep that in mind. We can, though, use fetal fibronectin and cervical length in combination, particularly in the high-risk patient. For example, in the patient who comes in to your OB emergency room or to your OB triage who may be having symptoms. She's not at increased risk. You get a cervical length and it's normal. You do a fetal fibronectin and it's negative, then these are the type of patients who can be out the door, whereas my nurse told me OTD, they're out the door with close maternal and fetal monitoring. So try to use the two in combination. Next piece of the puzzle is objective uterine activity monitoring. We use less than 4 contractions in an hour as normal. Where did that come from? As I always say, we made it up. We looked at the home uterine activity monitoring data that showed that patients are having uterine activity probably from about 16 to 17 weeks on. I'll never forget when we were using that device that we were able to document that indeed there was some uterine activity. We're not trying to wipe out all the uterine activity. And that activity was probably less than 4 uterine contractions in an hour. So we tell patients, I just told a patient, if you're having more than 4 uterine contractions in an hour for 2 hours in a row, contact your healthcare provider or invite yourself into labor and delivery. You can use 4, you can use 5. Sometimes the patient who comes in and out, we call those frequent flyers. You might want to increase that to 6 uterine contractions. But give this information to your patients. We need to get rid of the term Braxton Hicks contractions. There is no such thing. Braxton Hicks contractions actually came from studies years ago before a pregnancy test when a doctor would do a bimanual exam on a patient and she was early pregnant. And when he touched her uterus at 8 to 9 weeks, it contracted. And Dr. Braxton and Dr. Hicks called these Braxton Hicks contractions. It has absolutely nothing to do with preterm labor or the contractions that patients feel. So whether the contractions hurt or not, they are significant. I'll say that again. Whether the contractions hurt or not, they are significant. When a nurse calls me or calls you and says, well, the patient's having contractions 6 to 7 an hour, but they're not hurting, you don't have to say, so what? What you should say, use it as a teaching opportunity and say, for sure, it does not matter. So let's get rid of the term Braxton Hicks contractions. The next piece of the puzzle has to do with aggressive tocolysis. And as I put this together this week, I said aggressive has changed over the years. Aggressive tocolysis, as you can see here, we need to know when to use them and know when to not use them. Some are old, some are new, but none are perfect. We do not have the perfect tocolytic drug. When I have patients who I'm treating for preterm labor and labor and delivery, I always tell the patient, we have no perfect tocolytic drug. Nothing I'm going to do you is going to make you say, Dr. Hill, would you do it one more time? So for sure, the drugs are not perfect. They all have side effects, as we'll talk about them in a minute. You need to know the risk and the complications. You need to practice effective, evidence-based, and proven obstetrical interventions. You need to make sure that you know what those evidence-based new techniques and interventions are, and not be shy to change them or to share that information. These are the tocolytic agents that we have used over the years. You can see on the left, terbutaline, magnesium sulfate, indomethacin, and nifedipine, and you can see the various doses. Magnesium oxide seems to work in Mississippi, but not many other places. You can see indomethacin. We don't have it rectally anymore, so we're using a PO. It requires a loading dose, and you can see a nifedipine. But these are the doses of the drugs that we're currently using. We age ourselves when we remember that we used to use terbutaline and ridodrin. Remember ridodrin? When we used to use terbutaline and ridodrin IV. You need to know the complications of these drugs, because all of them have complications. I wrote an article some years ago about the risk and complications of using the tocolytic drugs. And these are just a few of the complications. With terbutaline, you know you're going to get an increased pulse. We suggest that if the pulse is greater than 120, the patient should not get their next dose of sub-Q terbutaline. Death can occur from prolonged subcutaneous use. We'll talk about that in a minute. Magnesium sulfate, of course, pulmonary edema. Death can occur and still occurs when the drug is given in high doses. Make sure when you are administering magnesium sulfate that you are validating the dose that is being given, that there's a nurse at the bedside watching that dose. If there's a disagreement between the dose, then the mag sulfate infusion should be stopped. Unfortunately, patients still die in this country from the administration of magnesium sulfate. You can see the side effects for indomethacin. You can see the side effects and the complications for nifedipine as well. One of the problems with nifedipine particularly are headaches and low blood pressure. Some of you in the audience take nifedipine for your blood pressure, so it should not come as any surprise when we give it to patients that it can cause a decrease in their blood pressure as well. There is some problem when using magnesium sulfate and nifedipine together, although many of us have, and many of us clinically would say that it's not a significant problem. But just be aware that when you use magnesium sulfate and nifedipine, you can get significant low blood pressure. Do they really work? That's a question that we've been trying to answer for years. And here in the ACOG Practice Bulletin number 127 from June of this year, Management of Preterm Labor, and I quote, provides short-term prolongation, speaking about tocolysis and also magnesium sulfate. However, no evidence exists that tocolytic therapy has any direct favorable effect on neonatal outcomes, or that any prolongation of pregnancy afforded by tocolytics actually translates into statistical significant neonatal benefit. Don't kill the messenger. So you can see that although short-term use is important, and during that period of time, we can give the patient steroids to help enhance fetal on maturity. Long-term use at this time is not of benefit. How long to treat the patient and when to stop? To answer this question, you need to talk with your neonatologists and your pediatricians. The practice bulletin that I just mentioned to you would suggest 48 hours, and when to stop, I think your neonatologist can help you there, whether it's 35 or 36 weeks. What about the FDA warning about terbutaline? We should not be using PO terbutaline at this time, and we should certainly not be using subcutaneous terbutaline pump. The reason we're not using PO terbutaline is because it doesn't work. And the reason we're not using the subcutaneous terbutaline pump is because of the complications that have occurred from it, including a maternal death. Is there a role for magnesium sulfate for preventing preterm birth and threatened preterm labor? There sure is. And as you know from, again, this practice bulletin, June of 2012, there are a number of protocols that have been published on the use of magnesium sulfate for neuroprophylaxis. One of the most common ones is by Dwight Rouse and the NICHG that uses magnesium sulfate for neuroprophylaxis. So if you don't have one, you need to search the literature and start using one in patients because it will decrease the risk of the baby having cerebral palsy. Let's discuss that. Now, what about the rational use of tocolysis? Make certain that the patient is indeed in preterm labor. Monitor the patient closely, particularly when you have a patient on magnesium sulfate. You want to make sure that her O2 sat is normal. Watch her fluid balance. Many of the patients who develop pulmonary edema do that because we are giving them too much fluid. Not only should we be listening to her lungs and monitoring her O2 sat, but we should be monitoring her vital signs. Know when to stop and when not to stop. When the patient says, I can't take this any longer, but when her cervix continues to dilate, then we should stop the drug. And obviously, stay up to date. Other important points about the rational use of tocolysis: employ special precautions with multiples, diabetes, mellitus, and anemia. Certainly with diabetes, if you're using terbutaline in patients who have diabetes, and if you give patients who have diabetes steroids, as you know, their blood sugars can increase and it may require insulin. So be careful about the patients who have diabetes when you're using those drugs. Know your own tocolytic cocktail well. It's not important for you to know how to use all 4 or 5 of the drugs, but come up with one regimen for your labor and delivery, or a regimen that your nurses feel very comfortable with using. Know that cocktail well, the way to give them the medication, and then the risk and complications. When you have a patient who does not stop, consider infection or abruption, because this may be the reason why you're having difficulty stopping her preterm labor. Many of us have been very aggressive about the tocolysis and then find out, she has an underlying chorioamnionitis, or when you do your ultrasound, you find that indeed she has an abruption. Stop the treatment for advanced cervical dilation, but then you have to decide what is advanced cervical dilation. It probably is not 4 centimeters. It probably is 8 centimeters. We've already talked about using fetal fibronectin and transvaginal ultrasound appropriate. If we use tocolysis, then use 1 course of steroids. But there may be times when a rescue dose of steroids under specific circumstances may be good. And this is a nice study done by my friend Tom Garidi that looked at the use of a rescue dose of steroids. You all will remember, this is why we need to keep up to date, that we used to have patients, today is Tuesday, and now let's give her her next dose of steroids. We would give weekly doses of steroids. But now we know that that's not the case. But what Tom showed us in a randomized double-blind placebo-controlled study, that with singletons or twins and intact membranes between the gestational ages of 25 and 32 and 6/7 weeks, and the first courses of steroids was given at least 14 days prior, that there was benefit in using this second dose of steroids. When he looked at the composite morbidity, you can see in the rescue steroids group 43.9%, and in the placebo group 63.6%, with no difference in birth weight or head circumference, which was the problem, remember, when we gave the steroids on a weekly basis. So it's important that we remember when we can use a rescue course of steroids. Continuing with the rational use of the tocolysis, prolonged maintenance therapy with oral terbutaline or oral procardia after IV therapy is ineffective and of no use other than the terbutaline or postpartum company. Sorry, don't kill the messenger. Now, nurses always ask me, and I know there are many nurses on the call, what about the doctors or the midwives who send the patient home on an oral dose of procardia or terbutaline, take 2.5 of terbutaline every 4 hours for the next 6 weeks? Well, we shouldn't be doing that. The data is very clear, and remember we said let's practice evidence-based medicine. The data is very clear that the maintenance dose of terbutaline or procardia as an outpatient, it really doesn't help. Discontinue the therapy in 48 hours if possible, and more data would say it should be in 48 hours, period. Be alert for postpartum hemorrhage. It should not come as a surprise to any of us on this call and on this webinar that if you have a patient who is on magnesium sulfate or on procardia or indomethacin or whatever you're using, and she quote-unquote escapes that therapy, and now she's in labor and delivery, and she delivers it very quickly, that the uterus is not going to contract. So think of postpartum hemorrhage and have your postpartum hemorrhage toolkit and your little box and everything all ready. Treat the whole patient, seek consultation when necessary, and stay tuned. And I think these are important points about the rational use of topholysis. What about when these patients rupture their membranes? Well, this can be a whole webinar, but ACOG certainly has a very nice practice bulletin on preterm premature rupture of the membranes. Remember, at this point, most of these patients we are delivering at 34 weeks. We are using appropriate antibiotics. We are using steroids. Let's move on and talk about the prenatal administration of IM progesterone. This was a NICHD double-blind placebo-controlled study performed by Dr. Meese, and they looked at singleton and with a documented history of preterm birth. Now, this is the group of patients and the only group of patients that were looked at in this study. Singleton, documented history of preterm birth. We'll come back to that in a minute. You can see the number of centers. These patients received either weekly placebo or 250 milligrams of 17-hydroxyprogesterone caprate, better known as 17P, until 36 weeks gestation. So that's when the medication should be used. Some of these patients had previous preterm labor, and some of them had previous preterm rupture of the membrane. The treatment reduced the risk of delivery at less than 37 weeks from 54% in the placebo group to 36% in the study group at less than 35 weeks, and you can see what it did at other weeks gestation. I want to point out that it reduced the risk of delivering preterm at less than 37 weeks to 36%. It did not eliminate it. These are the positives from the Meese study. It prevented preterm births in this select group of patients, and we went over the select group of patients. It certainly is encouraging and certainly is promising. But there are some problems. Sometimes the drug is not readily available. Sometimes when the drug is readily available, it can be costly. It leaves many questions unanswered that are worthy of further study, and those studies are ongoing. It did not prevent all preterm births in the study group. It still remains controversial, so stay tuned for more evidence. But at this time, certainly we are using prenatal IM progesterone to help prevent preterm birth in that select group of patients. It's not for twins or triplets. There have been a number of studies done that looked at using 17P in twins and triplets, and it does not work. It probably does not work because the mechanism of preterm labor and preterm birth in patients with multiple gestation probably has to do more with over-distension and not the same as in the patient with the singleton pregnancy where a lot of it is due, probably around 30% due to infection. It's not a part of acute preterm labor therapy. So when the patient comes in preterm labor, this is not a time to give her 17-hydroxyprogesterone. And as yet, it is not used in the treatment of short cervix. Perhaps it will be, and perhaps additional studies will show us that it is effective in that regard. But at this time, it is not. It is not to be used along with doing a cerclage. If you feel that the patient needs a cerclage, then yes, she needs a cerclage. But doing the cerclage in 17P, also, there's no evidence that we should be doing it. So these are important do-nots: twins, triplets, acute preterm labor therapy, short cervix today, and along with doing cerclage. So what about the incidentally detected short cervical length? No subject today is more controversial than this one. And ACOG tried to clear that up in a recent practice bulletin that came out last month in the October Green Journal in October 2012 on the prediction and prevention of preterm birth. And what I did was try to summarize for you where we are today, October the 26th. Vaginal progesterone from a number of studies in a patient who has a singleton pregnancy. She's asymptomatic. She's had no prior preterm birth, and her incidentally short cervix is less than 2.0 centimeters or 20 millimeters at 24 weeks gestation. And the study by Hassan suggests that these patients should be given vaginal progesterone. And there are several products, and we can talk about that during the question and answer period, that can be used for these purposes. One is Preterm. The second what and when is what we just talked about, and that's IM 17-hydroxyprogesterone. Again, singleton pregnancy, prior preterm birth. The third is tocolysis, if the patient's in true preterm labor. And that's always been an issue, is the patient in true preterm labor? And again, we talked about tocolysis and probably a benefit for 48 hours. During that period of time, we can use steroids and transfer if necessary. What about cerclage? A history of incontinent cervix, that makes sense. Or if she's on 17-hydroxyprogesterone and then develops a short cervix of less than 2.5 centimeters or 25 millimeters at less than 24 weeks gestation, or if she's had a prior preterm birth at less than 34 weeks and her cervix is short at less than 25 weeks. That's a real bugaboo on many patients. So cerclage may be a role. The latest, I'm always asked, what's the latest we would do a cerclage? And I think most clinicians would say 24 weeks. And then there are going to be some patients who have increased uterine activity and no cervical change. They fill up our OB triage, and these patients just need observation. And as I mentioned, a combination of fetal fibronectin and cervical length may be helpful with those patients. So I hope this is helpful to you. If we go back and look at these two practice bulletins again, there are two proposed performance measures, and I listed them here. The proportion of patients with preterm labor at less than 34 weeks of gestation who receive corticosteroid therapy. There have been a number of studies that have shown that that percentage in many centers, perhaps your own, is only 76%. Well, that's terrible. That means that we miss a fair amount of patients. Now, some of those patients we're going to miss because they come in and deliver too quickly. But there are patients who should receive steroids who are not doing it, and that's unforgivable. The percentage should probably be somewhere around 90%. The second performance measure is the percentage of women with a prior spontaneous preterm birth who are offered progesterone supplementation. Obviously, they should have a singleton pregnancy at this time, and that percentage also should be high. So these are two good performance measures for your QI department to be measuring. The next piece of the puzzle has to do with unknowns. And there are tests and therapies yet to come that we don't know about. Remember, if you think back with me, we used to use IV alcohol and thought that we were doing the best thing since Swiss cheese, right? And IV alcohol came in a bottle, and there were regimens on how to use the IV alcohol. I can remember administering IV alcohol and dropping that bottle on the floor. So that for sure, there are regimens now that we're looking at that we're not going to use anymore. And there are regimens that we haven't even thought about that we're going to be using. So keep in mind, tests and therapies yet to come. The second bullet is very important, and that is that there are ongoing right now, some of you are involved in them, clinical trials and studies about short cervix measurement, quantitative fetal fibronectin, and other studies. So stay tuned about these ongoing clinical trials. Many of them will be reported at our upcoming Society of Maternal-Fetal Medicine meeting in February. This is a slide that I showed you earlier, and look at that fetal fibronectin is a marker for labor, whether that labor is during mid-gestation or at the end of pregnancy here. And perhaps we could use fetal fibronectin. Dr. Greedy in another study looked at this in Mexico to help predict which patients are ready for labor. Suppose we use it in patients, for example, who are at 39 weeks, and I know that all of you know about 39 weeks now, to determine whether or not these patients were ready for induction. This is an area of ongoing research. The last piece of the puzzle is the challenge to you. And this is an area that many of us, myself included, have worked on for many years. We've tried to look at how we can prevent preterm births from occurring. We probably cannot prevent preterm labor, but how we can prevent preterm births from occurring. We need to teach and learn. We need to teach anyone who will sit still long enough. When you have a patient who comes in, doctors, when you have a patient who comes in and the nurse asks questions about, well, why is this patient in preterm labor, use that as a teaching moment. We need to learn from everyone else, particularly from our patients. Keep up and stay tuned. Follow the evidence wherever it leads us, and use accepted protocols. Using oral terbutaline after the patient goes home or using maintenance procardia is of no benefit. We should stop doing that. Don't give up or allow others to give up. It's unfortunate when we hear someone say, well, she's in preterm labor, she's at 35 weeks, we'll just let her deliver. That's not what we're all about. Treat the whole patient. Remember your mother-in-law at your house looking through your stuff. And most importantly, be proud of each little step you've made and will make on this journey. My wife, as some of you know, is in Rwanda working with the Clinton Foundation and helping patients and NICU nurses and labor and delivery units prevent preterm birth. And I tell her, and it's very challenging, the same thing. Be proud of each little step you've made and will make on this journey. And all of us should say the same thing. It has not been easy. It will not be easy. But we need to be proud of each little step that we made. And we're making a difference. Remember, it went down 0.3%. So these are the pieces of the puzzle. We've gone over all of them. We've tried to show you that each of these pieces has a real important impact on detecting preterm early and preventing preterm birth. You young things out there will be able to change what's behind each of the pieces of those puzzle over the years. And those of us who have done this for many years would say, yes, each of the pieces of the puzzle are important. We've learned from each of them, and we've tried to keep up. Are we there yet? My son, who is not 10 anymore, I think 35, I delivered him, so I should know, on the way to grandma's house, are we there yet? And the answer is no. Friends, we're not there yet. We still have a ways to go, but we are getting closer. So I hope that information has helped you. It should summarize, I hope, very nicely where we are. And let's see if we have any questions and answers. Thank you very much for your attention.
Thank you, Dr. Hill. We will now move to the question and answer portion of our discussion. As a reminder to participants, you can submit questions in the question chat box on the right side of your screen. Thank you, everyone who has sent questions so far and sent questions and comments. We'll try to get through as many of them as possible within our allotted time. I know a lot of people need to leave at the 1 o'clock Eastern Standard Time hour, but we will be on the line for a while longer. At the end of this question and answer period, we will also provide the Prematurity Prevention Network website, prematurityprevention.org, for those interested to learn more about preterm birth detection, prevention, and many other topics. Dr. Hill, in several areas during your talk, thank you very much, you provide your own algorithms in your own practice setting. During your talk, you mentioned your own algorithms, your own way of handling fetal fibronectin, the 4 uterine contractions, the tocolytic cocktail that you said you should standardize in your practice setting, and even the definition of advanced cervical dilation. How do you establish, communicate, and enforce these when more specific practice guidelines are unclear or absent?
Well, I think that the guidelines for, if I understand the question correctly, what we try to do is establish guidelines from evidence-based medicine. And there are enough guidelines from ACOG and published in other articles that I think help us to establish the protocols and our algorithms. Now, when we have a patient or in labor and delivery, what we try to do is to use those evidence-based guidelines. I'll give you an example. For example, in our 39-week rule, what we did was we took out Table 1 and Table 2 in an article that was published a year and a half ago, and we put that in labor and delivery. And we say, this is what we're going to use for our 39 weeks for those patients who should be induced. It's not easy, but that's the way that we try and do it.
Okay. Can you talk, this is a question from the audience, can you talk about the evidence around bed rest recommendations?
There is very little evidence about bed rest. If you look in the literature, very little evidence. I heard a presentation by a colleague who may even be on the call. Some patients use bed rest as a badge of honor. Certainly if a patient is in preterm labor, we don't want her up doing her normal activity, going to work, etc. And that's a good example of when she can go home and be at modified bed rest. I think most of us would agree with that. In patients who may be at risk, I don't know that there's any evidence that bed rest itself, and actually in the practice bulletin by ACOG, it says bed rest is not effective.
Thank you.
Let me interject. There are 2 practice bulletins that I would encourage our listeners to review in detail. The first one is June 2012, number 127, Management of Preterm Labor, And that bulletin is very helpful in telling us and listing a group of recommendations. The second is prediction and prevention of preterm birth. That was published as a practice bulletin in October 2012. And again, it gives a very nice summary of recommendations. I would encourage all of the listeners to get these two practice bulletins. If you're not a member of ACOG, a physician can certainly log on and get those for you. They're very helpful in trying to determine how to use these therapies or these tests.
Thank you. Our next question, I'm involved with centering pregnancy, which has documented consistent reductions in preterm birth. We think that group support for behavioral change is part of the benefit, as is the continued discussion within a health literacy framework that honors cultural beliefs and values. Any thoughts, Dr. Hill?
Good idea. Centering pregnancy is an area that we are using in several counties here in Florida. For those of you who don't know what centering pregnancy is, it's when we bring a group of patients in and go through her prenatal care, education, etc. More and more, we need to change prenatal care. Having a patient come in, taking her blood pressure, taking her urine, measuring her fundus, how you doing today, and sending her on her way hasn't changed in years. And we now know that centering pregnancy can be a real benefit. So I would say amen to that.
Thank you. In prevention of preterm birth and substance abuse in pregnant women, what treatment interventions have you observed to be most effective in relapse prevention? For example, outpatient services, medication maintenance, a residential program?
All of the above. We are finishing a syllabus that will be published in March in clinics of obstetrics and gynecology, clinical obstetrics and gynecology, and the issue is on substance abuse. I'm sure some of you in the audience are helping me with that. All of the above. It's a complex problem. Residential programs, when they are available, are very, very helpful. The problem with that is we don't have enough residential programs. Operation PAR and making sure that patients get their methadone from a reputable source is very important. When I see a patient, I'll see some this afternoon, they're on methadone. The first question I ask them is, where do you get it? And some of them get it from Operation PAR, most of them, but some get it from other sources. So all of the above are important, and this is a widespread problem, whether you're in Florida or whether you're in California.
Another participant asked the question, what are your thoughts on women taking opiates being sent to the methadone clinic? And it sounds like, could you comment
Absolutely, on that? Absolutely should be done. We have a methadone clinic in our area. You have to work with those clinics. They do a good job because the patient is on an opiate. She can't stop the opiate during the pregnancy. She needs to continue the opiate or methadone, and it needs to be done under some kind of a controlled situation, okay? So the controlled situation is the methadone clinic. So we get these patients into a methadone clinic, so she's not getting methadone from a reliable source, and we're able to follow her. Some of them go to a residential program, and we follow them as well. So we definitely afford that.
Okay. Changing gears here a little bit, how can we get our girls before they get pregnant for preconception education? Is there any funding for this, and what are your recommendations?
In Florida, there is funding, and Florida has a very robust Department of Health, and there was funding and still is funding for preconception care. So you need to work with your State Department of Health and see if you can get funding for that. What the funding in Florida allowed us to do was to give lectures around the state on preconception care.
And of course,
you also can work with your local ACOG group. I'm sure that your ACOG and district ACOG office can help you perhaps with a grant or some suggestions on how to incorporate preconception care.
And moderator's privilege here, I'll also put in a plug for March of Dimes prematurityprevention.org, which has on it many references and resources for preconception care along with many others. The next question comes to us and says, what about adequate hydration? Does adequate water intake help reduce the onset of preterm labor, or is this a myth?
It's a myth. There have been a number of studies done that looked at it and whether or not hydration and dehydration increases the risk of preterm labor. Here in Florida, we see patients who are dehydrated. I think the most important thing we see from that is there's decreased fluid around the baby. There's oligohydramnios. What we do and what has been shown by a number of investigators is we encourage our patients to drink, or if it's really low, we have them come in and we give them an IV and have them drink. So it does cause oligohydramnios. I'm not sure of any evidence that has shown consistently that dehydration increases the risk for preterm labor.
Switching gears again, what do you suggest using for preterm labor in multiples, specifically twins? And when is preterm labor in twins?
Well, preterm labor in twins is the same as it is in anyone else, unless I'm missing the question. If a patient has increased uterine activity and cervical change, she's in preterm labor, and usually we define that as after 20 weeks. What was the first part of the question? Oh, what do we use?
Yes.
The same thing that we use in other patients. There's been some evidence that the pessary is of help in the multiple gestation. My colleague, John Elliott, has had some success with that, and certainly the multiple gestation. So the pessary may be something else to use. We have not used that, but certainly other investigators have. Going back to the previous question about hydration, in the management of preterm labor practice bulletin, it states bed rest and hydration have not been shown to be effective for the prevention of preterm birth and should not be used routinely. I think that answers that question.
Yes, I believe so. And another intervention is 17P. Do you have any opinion on using compounded 17P as opposed to brand name?
Yes. Thanks for that question. Let's not get into the brand name, but the point here is, can you use compounded 17P? The answer is yes. As you know, the FDA made that very clear. I will say that if some of your patients received it from the compounding pharmacy that has some issues at this time, what we did at our place was reassure the patients that the issue with that pharmacy had nothing to do with 17P, and we found another source for it. We have a compounding pharmacy here in our community. But certainly using 17P from a compounding pharmacy is legitimate, and we and others are continuing to do that, and I dare say most of you on the call have done it as well.
Two questions again about preconception care. The first is a comment that says a wonderful program that provides preconception care education in addition to the March of Dimes is the Nurse Family Partnership. We certainly appreciate the comment. And the second is around preconception education. Dr. Hill, do you believe that churches should be offering preconception education?
Well, I don't know that the churches should be. I think that it's an opportunity. Those of you out there who have a connection with your church, and churches are always looking for other projects to do in a community. And many churches in our area have a nurse or other programs. One of the churches nearby had a program that received, I think, a little award, because what they did was they were able to get teenagers and young girls of reproductive age to come in. We're giving talks on contraception, other preconception issues, self-esteem, etc. So this is an opportunity for churches to work together and for churches to do something. And remember, grandmothers. Grandmothers are very important teachers, mothers, people who are well thought of in the community. All of these individuals frequently are going to church and can use the church as a way to reach out and give out information.
And even mothers-in-law, so long as they're not back at home going through your stuff?
Even mothers-in-law, as long as they're not at home going through my stuff. A patient actually told me that.
Dr. Hill, what is the role of preconception counseling in preventing preterm birth? Does this really work?
It's a part of education, is it not? It's a part of education. Does it work? Whatever we've been doing has worked just a little. So I'll leave that as the answer to that question. I think that it helps educate patients before they get pregnant. And I think that's what's important. And then certainly it can help educate patients who are pregnant. So the answer to the question, I think, is yes.
Going back to a previous question, Dr. Hill, you've created a bit of a stir online here with questions and answers. The follow-up question to your bed rest comments is, so is bed rest not recommended for preterm labor?
Again, bed rest and hydration have not been shown to be effective for the prevention of preterm birth. It should not be returnally used. So it doesn't prevent it. There's no question that bed rest or hydration does not prevent preterm labor or preterm birth. Now, if we send a patient home, I send a patient home who's been in the hospital, she's had preterm labor, she's received a tocolytic, she's received her steroids, and now she's going home. Things are quiet. Can we say to her, you should be on modified bed rest? I don't want to see you at Walgreens. Use this as an opportunity to get some rest at home. I think that's all very good and very important. I ask the patient, so when you're going to go home now, what are you going to do? What have you been doing here? And the patient says, nothing. I'll get my mother to help me. I'll get a friend to help me. I'll get somebody from church to help me. I think that is effective. I think that's a part of the therapy. But to a patient who's at increased risk, to say, go on modified bed rest, I don't think there's any evidence for it. And I think the practice bulletin agrees with that. That's the best way I can answer the question.
Thank you. What about Kegel exercises? Do they affect preterm labor?
No. The question always comes up also, what about sex? Does that increase the risk for preterm labor? Well, I think if it did, the rate would be higher than 12.3%. And I think that for the most part, patients who are at increased risk can still have sex. Those patients who, for example, have are home at 3 centimeters, who we've had in the hospital, and we send them home, or patients, for example, the one I have in the hospital who has an abruption, who probably will end up going home on some modified bed rest. We suggest to them that they not have sex. There was a study done, not actually by OB residents, looking at increased uterine activity after orgasm, and they found there was some increase in uterine activity, but it did not lead to preterm birth.
And a follow-up question, are you familiar with Elizabeth Noble's prenatal exercises, and what do you think of her program? Do you think certain pelvic floor exercises early in pregnancy in the first trimester can help?
I must say I'm not familiar with that, so I don't have any comment.
Okay. What is being done in other countries with lower preterm labor rates than what the U.S. is doing right now? Or are we doing nothing?
Well, I don't know that other countries are doing anything different that we are doing. I'm not aware that they're doing anything different. I think that countries that have a lower rate probably have a different population, a more homogeneous population. I think that's why they have not only better statistics in this area, but in other areas as well. But I'm not aware of any specific therapy that they are doing that we are not doing. We'll be leaving Florida in January and going to Rwanda and doing some things there. And we're going to take the same things that we just talked about, hopefully there, to help decrease preterm birth.
Use of the pessary is there's more use of the pessary in Europe than there is in the United States. Do you think that may be a factor?
It may be a factor. It may be. But I think it's more a homogeneous population where the risk is going to be lower to begin with. The background risk is going to be lower to begin with.
Okay. Another participant asks a question, changing gears again. If we have the name of the study related to the Procardia use in preterm labor, we may be able to post that online if we can find the reference for it. But a comment follows from a different participant. She says, excellent presentation. I'm a long-time labor and delivery nurse, over 40 years. I remember when we used IV alcohol in attempts to stop or slow down PRL. So there has been progress. I wish more of the physicians in my location were listening to this presentation because they're still discharging patients with prescriptions for Procardia or terbutaline. And again, thank you so much, Dr. Hill, for very good information.
Well, thank you very much for that comment. Boy, a nurse of 40 years, she's my vintage. Thank you so much. One of the things that we try to do, and more as I speak around the country, is to share with your physicians the evidence. I still believe that if we share with physicians the evidence, the practice bulletin, the practice pattern, the committee opinions, articles such as the one I mentioned about 39 weeks and when we should induce, if you share that information at your department meeting, if you leave it in labor and delivery in a conspicuous spot and share it, most physicians will buy into it. I mean, for physicians to continue to use maintenance tocolytics when it says in the practice bulletin that we should not, I mean, you're going against the evidence. Clearly, we should not be using terbutaline as a maintenance drug. In terms of the studies on PO Procardia, we're going to search Procardia maintenance therapy. There are at least 3 studies that I'm aware of that say it's not effective.
Another participant asks, we have heard from moms that their OB-GYNs will not take them in early in the pregnancy, especially when we're trying to get the moms early in the first trimester for adequate prenatal care. Do you know why this is so? This will be a deterrent in detecting preterm labor.
The question was, would not accept them to come in early in the pregnancy?
Correct.
The only reason that I can think of is an insurance issue. If it's not an insurance issue, then they should come in early. Occasionally, we will have patients who do not come in early because they're on Medicaid and the doctor's office insists that they have some form of insurance. But short of that, I'm not sure why a physician's office would not have a patient come in the first trimester for better documentation, for example, which would be important.
Okay. At this time, I'm going to invite participants to put in your final questions. We will only have time for a few more before we need to close out the question and answer period. So if you have any final questions, please type them into the box at the right-hand side of your screen. The next question for Dr. Hill says, or it's a statement, I believe, I've been to a conference that stated that methadone is causing prolonged NICU stays, and the preference is to keep the patient on the lowest dose of the drug of addiction. That is in response to our previous conversation about methadone and
right.
and where we should refer these patients. See if there are any. Sorry, I'm sorry, Dr. Hill.
That's all right. I got a slight cough. The listener is correct in that patients who are on methadone should be on the lowest possible dose that takes care of their symptoms. If they're on methadone and they come into the pregnancy, the methadone should be continued. Occasionally the dose will need to be increased because of their blood volume going up. Now, in terms of babies in the neonatal abstinence syndrome, a big problem. Not all babies go through neonatal abstinence syndrome. Depending on the study, it's somewhere around 40 to 50%. But those babies who go through neonatal withdrawal syndrome end up being in the nursery and in the hospital or in pediatrics in that hospital. It can be for a long period of time. We have a little brochure that we give to patients who are on methadone, sharing this information that your baby will be in the hospital for a longer period of time. So the listener is correct in what she said.
Well, thank you, Dr. Hill. On behalf of the March of Dimes Foundation, we would like to thank the National Medical Association for their support of and collaboration with this event. And of course, we extend our thanks to our speaker and presenter, Dr. Washington Hill. And thanks to all of you, our audience, for joining the conversation at the Prematurity Prevention Network. To learn more about the preterm birth prevention and detection, the Prematurity Prevention Network, or any other topics, log on and sign up at www.prematurityprevention.org. As a reminder, you will be receiving an audience survey with instructions on how to access the archived version of this webinar that Dr. Hill just presented. Please complete the survey so that we can continue to provide you with the most relevant and important events. Dr. Hill, do you have any closing comments for your audience?
Keep on keeping on. And thank you so much for your attention.
Thank you very much, Dr. Hill. Thank you for participating. This concludes the webinar. Thank you all for joining the conversation at the Prematurity Prevention Network.